Good afternoon. Welcome to National Symposium of Istanbul, Kent University and Trquoise Study Club. Today we have a guest from Mexico, Professor Sergio Ariosto Hernandez Delgado. He's going to make a presentation on progressive rational invasiveness in anterior dentition. But before his presentation, I would like to introduce him to you. He graduated from the Faculty of Dentistry of the National Autonomous University of Mexico. He completed his master's studies in dental sciences in community dentistry at the same university, and his research experience was in dental biomaterials and clinical epidemiology. He participates in various refreshers and training courses in Mexico, Europe, and the United States. Also, his private practice has a focus on preventive, restorative, and aesthetic dentistry since 2005. He's professor at the Comprehensive Dentistry Clinic and the postgraduate restorative dentistry at the Technological University of Mexico. He's fellow of the Pierre Ford Academy since November 2014. He's a clinical consultant for many dental companies. He's a national and international speaker. Welcome, Professor.
Thank you, Professor Ezra. It's been a pleasure for me to have this invitation and be able to share a little bit for what we are doing in Mexico and dentistry that is a passionate labor for all of us. So I'm really glad to be here.
Yes. How are you doing in Mexico nowadays?
Is
everything okay?
Basically, we have what they say the third wave, but you can see at the traffic that most of the people are not afraid of coronavirus anymore, as far as we see, and that's a thing that actually concerns us a little bit because we're probably facing a new lockdown. Hopefully not, but it's possible due to the conditions we're facing now. But I hope I might be wrong, and the epidemiological data might improve and we get better.
Yes, we hope also. And I think it's the first time you make a presentation in Turkey. Am I right?
Yeah, it's my first time. I'm honored, and actually I'm pretty nervous.
Okay, also we also looking forward to follow your presentation. If you're ready, let's start. After the presentation, we're going to take the questions, okay?
Perfect. Ready. Okay. There we go. Okay, and...
share. Yeah.
Perfect. Here we go. All right. So, I don't know if you can see this.
Sorry, but we couldn't follow your slides now, your PowerPoint slides.
Yeah. I think I'm sharing the slides. That you see the first one?
No, we couldn't see.
No? Let me see.
No. Now we can see your slides. Okay.
Perfect. Very good. There we go. Sometimes the keynote plays some strange things.
Yeah. Yes.
Very good. So this is one of my favorite places in Mexico City. It's the National Anthropological Museum, and I really enjoy all the content here. It's a very peaceful place, a very nice place to visit. So I hope when you have time to come to visit, you have to take 1 or 2 days to step inside the treasures we have holding here. And officially, I would like to welcome you to this presentation that I have tried to address most of the common topics that we try to face on our daily practice when patients come looking for improvement in the anterior dentition. And I would like to address this topic with a perspective that is pretty much like a state-of-the-art concept where we can see light and shadows, and with this contrast of people going to restorative dentistry by using a biomimetic approach, and other that are more invasive approaches. But all of them are intended to improve the quality of life of patients. So I could not say one's better than the other when it comes to moral concern or perhaps validation way of thinking. But I can say that what we have pretty clear is that we have to state that when it comes to dentition, especially in the anterior dentition for patients, they face the need to be on the possibility to make a fast improvement. They try to look better. They try to they want to feel better. They want to go to a better approach of what they consider the perspective of themselves. And one of the most important things that we can share with our profession is that we can do this effectively and almost instantaneously. And what I consider the most important thing is that we have the chance to establish a long-term commitment with our patients. Therefore, I want to address this topic that we call the progressive rational invasiveness, because we start trying to avoid the need of restore. And when we start with this, we have to consider this correlation of concept, because the correlation of structural affectation and therapeutic invasiveness, we can see that there's a complexity and risk increasing as the evolution time and damage increases as well. So that increases also the invasiveness of the procedures that are going to be needed to restore and to repair the condition of the patient and rehabilitate them. And biologic cost is also increasing. So the patients sometimes are not aware of it, and they ask for specific needs to be solved. For example, in this case, we can see a patient that has been restored since she was 18 years old, and she's a patient that is a magnificent patient, passionate and dedicated architect, and was not happy with what she had in the mouth. And here I have another patient. He was also a great architect as well, and he was not happy with his smile for the past 52 years. So it was very difficult to give him what he was expecting. And here we see another case with conditions that are complicating the aesthetics, because you have a gum height that are not positive for the display of the smile. And you can see also that there are different shapes and forms of the tooth that are making it a little bit more difficult to have this patient happy with his smile. And what you can see here is also a patient that has a fluorosis and also has problem with the alignment of the tooth. And this picture is 4 years after orthodontic treatment started. And to reach them, to bring them to this point, sometimes very difficult, because they need to understand that the need of the treatment is not only a superficial treatment. You need to share with them all the perspective and the view of what you can do with what you have, but what you could do with what you don't have. So these cases are very, very challenging. And here we can see also a patient with a very difficult smile and a very complicated situation for me, because she had only the chance to travel to Mexico City for 4 days in a row, and then 4 days in the second one. And I have to streamline the process to have all this together in 2 visits from this patient, having a very short time frame. So we try to do our best, and I will show you later on the results. And here also I have a great patient. It's a very good patient that afterwards came a friend. It's a German guy whose father is a engineer that was working for a dental company, and he was looking forward to improve his smile, the quality of his smile, and his quality of life, actually, because he was not happy with his smile. And the father decided to recommend him not to do the work in Mexico, because he didn't expect to have a nice treatment here. And I was very happy to deliver something that he liked at the end. And then we come back to this ratio graphic, and patient-wise, it's more easy to understand that the more you're close to prevention treatment, it's much better than going far away from the follow-up of the professional treatment. And eventually, you know that you are going to spend a lot of money, and then you have to spend a lot of time. And I tell my patients in this way, you have to spend a lot of shared time with me. So this is very costly, not only because of the economic cost of it, but psychologically, biologically, and for the patient, the invasiveness of the treatment starts with the time they have to invest with us in the chair. So we can go to this graphic of Tilstrup and Fagerskov in 1986, and that shows us that we have much more times to prevent the damage than the opportunities we have to restore damage. Because once the cavitation is present and symptomatic conditions start, the patient start to look for the treatment, and sometimes a treatment that could be oriented in a more selective way and a better time oriented and effectively oriented when it comes to clinical minimizing the damage approach is not possible anymore. And once you have a total deterioration of the tissues, it's very complicated, because sometimes patients are not having enough tissue to be restored, and we cannot take advantage of it anymore. And the three most complicated times that we can face once the restorative cycle started is, first of all, understand the most common causes of the need for restoration. And when it comes to anterior and posterior restorations, we have to consider these three specific entities that are caries, trauma, and perhaps erosion. And sometimes we can see in cities like Mexico, it's growing. I don't know how is it the epidemiology in Turkey, but erosion is growing very fast. We have more patients that are linked with gastroesophageal reflux disease, and also they have sometimes a complication of bruxism. So caries, trauma, and erosion are the most common causes for patients to bring themselves to the clinic looking for fast treatment and fast delivery treatment to improve their quality of life as soon as possible. And then they have also the possibility to start a treatment that allowed them by means of a preparation, sometimes a small preparation, sometimes a primary preparation rather than the use of planimetric preparation that is more destructive. But the preparation is a moment that has no way back. So once you have to prepare a tooth, you are removing a tooth structure that is not going to be back anymore. And then you have to consider that this restoration that was placed in the mouth by means of a preparation will be able to work there only for a time. And then later on, it's going to be needing a replacement. So for patients that are looking for an improvement in their quality of life, like this patient, we can offer an entire rehabilitation by means of using aesthetic materials and using all the ultimate technologies that you can have in hand. But what is behind it? What are the concepts that are leading us to this new view of the dentistry that has been going in back and forward for the last 30 years? And I can call this biomimetic approach a great tool for us, because it allows us not to create only perfect smiles in patients that are model-like, but we can deliver lifelike restorations for patients that are as normal as ourselves. So for these patients, for these everyday patients, for these normal life patients, we can deliver restorations that are not only aesthetically driven, but biologically driven, in order to achieve the maximum time of follow-up. And I really like to see the things like Professor Tucker in the United States says, and states in 1957, as far as I remember, that you have to consider that the restorations are gonna be there with the patient along their lives. So we have to consider that once you start the restorative cycle, you start a cycle that has no way back. And you have to think in the best possible way, the best way to minimize the damage and to optimize what you have in mouth. So 60-year-old patients starting with caries, a first molar that is going to this complex environment that is the mouth of a patient, we can see that in this kind of cases, we start by drilling and filling with composite a new tooth. And this is a point of inflection in this life, because then later on, as the years come by, this tooth will be needing a new restoration, perhaps because of secondary caries in a worst case scenario, but in best case scenario, perhaps it's only because the composite filling has been wearing and tearing and deforming its structure as long as it served. So you need a new one. But the tooth structure, the remaining tooth structure is fine. So you don't have to invasive, you don't have the need for a major invasive procedure because you have a natural tooth structure that is in good conditions. And that depends on the approach that was made by the operator at the very, very, very beginning. So then you come to the next scenario. Okay, what happened 10 years later? Perhaps the material has also a deflection problem, or perhaps it was wearing, or the margins are losing the fit. And when the patient is reaching his 30 years, secondary caries attacks him again. But now, instead of using a composite filling, because of the invasive capacity of a bacteria under restoration and this peri-restorative failure, we have to go to a secondary restoration that comes with a ceramic overlay, for example. And then a few years later, when the patient is reaching his 40, we have again secondary caries after this treatment, and we need to go to a root canal treatment. Then we go to the crown, and then we have very minimum tooth structure to save. And when the patient goes more advanced in his age and his elderly stage, the tooth extraction comes into the scene. And then we have perhaps to think in the implant-supported crown, and that's the life cycle of that tooth ended up. And then time goes by, and then we have 81 years old patient with peri-implantitis and the need of explantation. So we don't have to consider that the restorative cycle is only affecting tooth structure. The restorative cycle goes also to restorations that are in the mouth. So when you have to think, if you need to start this restorative cycle, you have to think, how deep is deep enough? How deep do you need to go inside a tooth structure? How tough is going to be your surface? What type of material are you going to use to prepare the tooth? Because you need to minimize the damage. So the fastest you go and the roughest the burr, you do a biological damage that has no way back. And this, for many restorative dentists, is something that we only consider when we are going to the direction of prosthetic work. But it works for every level of restorative dentists, from the pit and fissure sealants. And sometimes we have to modify the pit anatomy because we need to open a little bit, because the retention of its anatomical shape is so difficult to clean that we need to modify it to have better performance of the preventive strategy long term. But when it comes to prosthetic work, it's a little bit more difficult to think about it. And I like to think in the way that Pascal Magny wrote in his article about 3D, 2D, 3D, and 4D way of thinking, and try to train your hand and your brain in a way that allows you to be able to imagine that you are into the tooth, and you have the capacity to go back and forward in the reconstruction of the 3D shape of the tooth, and the 4-dimensional when it comes to the reduction of the tooth when you're preparing the space to create a restoration. So we have to keep in mind this biological concern of how close are we from this sensitive parts of the tooth. When we are preparing a tooth, we have to consider that the pulp degradation is one of the most important concerns of every restorative dentist, because we have to be aware that there are many things that we have to consider before we start the prep of the tooth. We have to be able to have all the armamentarium and equipment, and the most important thing is to have the biological conscience that when we go deeper in the tooth, we have to reduce the speed. So that biological logic of dental preparation allows us to have a better stability long-term of the remaining tooth structure that we are preserving, or we are aimed to serve to the patient, trying to preserve it for as long time as possible. So invasiveness is a ratio that comes with the capacity of increase the amount of procedures and the force we are going to use against the tooth structure and the restorative materials that have been passed over with the needs of the patient's function. So we have to consider that this invasiveness allows us also to consider many other things that are very important aspects that I take from this Stephen Fallon chart that he published in 2018, pretty much like a modification of the ITI SAC guide. And you can see that the risk, the invasiveness, the length of the treatment, and the costs that are going to increase as far as the patient increase on the demands of multidisciplinary treatment. And this invasiveness is linked to the capacity of the patient to be part of a treatment by adapting his behaviors to a more preventive behavior overall. So if the patient is not aware of what caused him the damage that led him to the condition that he's facing now, when we are starting the process of restoring his tooth structure and his dentition, they will not change those habits that were able to damage his health. So we need to make them be absolutely aware and to see the same movie that we are seeing and to see the same picture, because otherwise they're going to behave in a way that will be able to jeopardize the long-term stability of our work and of our restorations. So you can consider many factors that comes from the aesthetic demand, the biological risk, the biological aspects, and specifically speaking, the amount of bite, the force that the patients are going to apply to the materials, and the remaining tooth structure. And this is very important to be considered, because sometimes we forget a little bit about biomechanics when we are preparing a tooth, and we try to go in the most minimally invasive way, but we forget to do this minimally intervention treatment approach. So it is not the same to go minimally invasive, try to destroy the least tooth structure as possible, but minimum intervention is to treat a patient today and then I have to treat something 20 or 25 years later, because I did enough treatment invasiveness and enough treatment considerations to have the long-term stability almost guaranteed. And we all know that in dentistry that is not possible, but we try to go evidence-based, and we try to go to follow the directions of what has been tested in many studies. And when it comes to restorative dentistry, the contemporary approach shares with us these concepts. We must prioritize preventive dentistry in our minds, in their mindset and the mindset of the patient, because the patient are going to go to our clinic looking for treatment that sometimes could be part of a sort of preventive treatment. But if we are not able to show the patient the benefit of this type of approach, they will move on in the traditional way. So non-invasive treatment is desirable. It's absolutely something we will to have the chance to apply. But also, we are looking now for the possibility of reintervention, of being able to have enough tooth structure in the timeline, in the future, to be able to restore again and to have something to repair again. And then the possibility of repair of the materials that we are using now is something that allows us to offer to the patient something that is more cost effective. And biologic integration of the restoration will be able also to allow us to deliver a restoration that will be stable in the long term and will be respectful of the biologic relations between the tooth and the periodontum and the restoration with the function of the stomatic system as well. So aesthetics optimization is also one of the challenges that we are facing in this contemporary restorative dentistry approach, because most of the patients are not looking for the well-proven, most durable restorations that were the metals, and they are looking for new materials that are more aesthetic and are looking for also long-lasting materials that are very difficult sometimes, but the companies in the industry are now providing us with these materials. And we have also to be able to give to the patient one more opportunity when it comes to tooth preservation approaches. So people like Professor Daniel Busser in Switzerland, in Geneva, is asking to postpone the implant placement whenever you are able to do or perform any adhesive treatment. So the advantage that we have now in this age of adhesive dentistry is that we have this revolution of contemporary restorative dentistry based on these three groundbreaking advances that in the timeline of adhesive dentistry we can see. Since Michael Warncore started with this modification of dental surfaces by acid etching, we started to have this new approach of the techniques and technologies that allows us to develop a composite of resin metacrylate-based chemistry. And this new type of materials are evolving constantly. But it's very funny to see that we are still using molecules that were developed in 1940s, and they're very good, and they are using a very stable in the long-term follow-up phosphate chemistry, like the GPDM, for example. And then we can see also that then came later on the development of hydrophilic resin chemistry, and now we're in an age where we can see that based on this chemomechanical tension phenomenon, supported with this resin metacrylate-based chemistry that allows us to fill the spaces and to increase the retention, trying to copy or mimicking the dentin enamel junction, we're looking to have a better scope when it comes to make a restoration become part of a tooth. And that's what we see in the biomimetic approach, biomimetic dentistry. I'm sorry because this is in Spanish, I wasn't able to translate it, but these are the rational elements that we all consider today in the restorative practice, in the adhesive restorative practice. We have to be very conscious of the histomorphology, or histology and morphology applied on a clinical way. And I really like the way that Panagiotis Bassos and Pascal Magni addressed this topic in an article in 2014. And they let us know with this histomorphological approach, a very good way to allow us to reconstruct not only the aesthetics or the function in the overall terms, but the specific part by using very interesting combination of properties of the materials, optical properties, mechanical properties, with a biological affinity of the restorative material to increase the capacity that we have to deliver a lifelike restoration, but biomimetically imitating all the capacities of the tooth for function. The strength of the enamel, its hardness, and the flexibility, the resilience of the dentin, and also the capacity of distributing the forces that when you're biting, you apply to the tooth structure by using adhesive materials to create something that is very much like the dentin enamel junction. And we also were more prone to go to this approach, trying to preserve the histology, try to preserve the most sensitive to the structures that are dentin enamel junction, and try to move as far as possible from the subgingival margins. So we have to be able to develop skills and to perform treatments that keep us there. Because when we are more invasive, histologically speaking, we have to consider that the cytotoxicity of the materials that we are using in our everyday practice, and the invasiveness of the process, and the biological damage that we can create by means of burr heating, of excessive heat by means of polymerization light, and also the chemistry that we use sometimes is too aggressive and give us very, very complicated pH to be solved by the tooth structure, and the chemicals that we are using are powerful enough to modify the dentin itself by means of only the presence with rubbing a little bit, 15 seconds. It's much more than enough sometimes, because we are using mildly acidic adhesives, but in the past we used strong adhesives, strong acidic adhesive monomers. So we are also in the possibility today to create these tooth structures that the patient has been losing with previous restoration, and create this conscious in the future generations of dentists of use this biomimetic approach by creating the dentist patient communication and building a confidence relationship as well, because we are preserving their biology and reconstructing their biology by means of all the capacity that we have to create restorations that are not only lifelike, as I mentioned before repeatedly, but we try to imitate the biology, the function, and the capacity of the tooth to create this functional resolution and aesthetical resolution. And it's what we see here in this graphic. So sometimes the adhesive restorations are allowing us to restore the function by means of subtractive techniques and additive techniques. And these techniques are allowing us to create the more strong system of tooth structure and restorative material combinations, and they give us also the chance to improve the capacity of going lifelike approach by means of using the most advanced optical properties that we have in the market at this moment in our history, because we have such a big scope of materials that we can use for many different applications that can give us the chance to recover the optical properties: translucency, iridescence, opalescence, fluorescence, and color. And the first one I want to share with you is the first approach when it comes to restorative dentistry and going to the minimum invasive treatment. You all know the application of this type of infiltrative resins that are meant to reduce the amount of accessing of hydrogen ions inside the hydroxyapatite structure, and giving us the chance to preserve by means of a sealant, of a material that is transparent and allows us to bring back to the tooth structure the reflection index, and gives us also the chance to preserve the biology and the structure, the overall scheme when it comes to the capacity of the patient to preserve a compromised tooth structure. Perhaps from the beginning, because of the formation of the tooth was not good enough. We have some problems, like it can be fluorosis, and it can be also amylogenesis imperfecta that is very common as well. And we have this type of issues that have been addressed in the past with more aggressive approaches. So we can clean the tooth, we can sandblast the tooth, we can apply 16% hydrochloric acid gel to create this microscopical gaps and create these spaces that are going to be filled afterwards with material that is composite dressing, but it's our composite dressing with very specific characteristics that are it's basically material that has no a filler load, and that doesn't allow us to have a major resistance advantage. But we can see that we can be very conservative when it comes to the restoration, because after we clean and we apply the hydrofluoric acid to create the microscopic retentions, we can create these micro gaps to perform restoration so small that allows us to bring back all the natural shape and the shades, and also the aesthetics that the patient is willing to have. And once we have this cleaned tooth structure, when it comes to microscopically observation, and we can see that the microstructure is perfectly cleaned. We have to remove all these particles that were part of a process of aeroberation, but we can see also by means of transillumination the position of the lesion and this capacity that we have with the material to bring back the index of reflection. And with this reflection index recovered, the tooth structure will be protected and will be aesthetically improved. So the patient is going to be receiving, by means of this minimal invasive treatment, one of the best possibilities to have immediate change for the patient expectations. And this treatment, I cannot say is reversible, but it's a treatment that is so minimally invasive that the damage that it causes to the tooth structure in the long run is not enough to compromise its vitality or its capacity of being able to be restored later on. What you cannot do, absolutely, is to bleach afterwards. But when you need to go in this direction, you can bleach before, and then you can see in the transillumination image, in the control image and the follow-up, we can see that we obtained a very good cover of these damages that were microscopically present in the previous images. And we can see that the index of the light passing to the tooth structure, to the material, doesn't create something that separates visually the presence of the material on top of this tooth structure. And we can be very conservative, and we can go to a very thorough polishing process that allows us to give to the patient the possibility to have this type of restoration for more than 7 years in the mouth. That is the current average that I have been facing in the past years since I started using this technique, and this icon material change my possibilities of treatment and allow me to have a broader scope to go to a direction of doesn't affect the microstructure but improve it. And instead of going to a drill and fill approach, I can go to a microscopical filling, and then I can keep on prevention by means of the application of dental fluoride varnishes that are specialized to allow us to increase the mineralization of these specific risky zones. And you can see that in the long term, the stability of this type of materials is very good, but we have to consider also that the biology of the patient will be sometimes not good enough if the patient doesn't take care of the cleaning properly. And the most important thing is that we have to see that the balance of the tooth structure biology and stability when it comes to the presence of bacteria in the biofilm and periodontal stability are very close to each other. So if the patient is not taking care of these fine spaces, these close spaces to the gum, they can compromise not only the biology of the tooth structure biofilm, but also they can compromise the stability of the periodontum. And that is a major concern for us. Then in conservative and restorative dentistry, there's no place to avoid this part of reality and link this communication to the most possible highest level of awareness in the patient's minds. So the patients need to be aware that these microstructural changes are the ones that started the damage and that will start the damage later on. Okay, and by means of professional polishing and care and follow-up and giving them support and orientation and information, we can increase the awareness. But we cannot go to their homes and clean them their tooth at home. We would like to sometimes, but it's impossible. And we also have to consider that when we bond something to the tooth structure, there's a degradation that it's going to be capable by means of a hydrolytic phenomenon and enzymatic processes to change the stability in the long term and compromise the possibility to have better integration of the restoration. There are causes of failures of the adhesive dentistry that are linked to the bonds between adhesive and dentin, adhesive and resin, and adhesive and enamel, as we can see in this slide. And we can see also that in this Pedro and Russo's article, we see that now we are facing a time where we are not only concerned about the bacteria invasion, but also the host-derived proteolytic enzymatic phenomenon of degradation of the resin-dentin bonding interface. And when the work of Professor Nakabayashi started in 1982 to create this consciousness that we have now of how the hybrid layer creates and how the hybrid layers is linked. This magnificent picture is from my friend Umar Dawood, that is now in Kuala Lumpur, Malaysia, and we have this beautiful image of the dentin bonding that is the most difficult bonding to achieve. And we have to be very aware and to be very clear in this minimally invasive consciousness and approach when it comes to trying to reduce the damage we create in the time of the lifespan of the patient's restorations history. Biological reality of the patient. The patient has a history of caries, periodontal problems, and perhaps an exposition to microbiome coming from the parents and relatives that in the life became part of our biome, of microbiome, sorry. So we also have to consider that there are major concerns when it comes to structural damage. The structural damage allows us to be as conservative as possible, specifically when we are trying to use this more called not geometrically driven approach, but a more histomorphological driven approach. Therefore, knowing the structures and knowing the physiology of the tooth, the biology of the pulp, and the histomorphology, we can create a better combination of materials that allows us to have the better biomechanical combination of materials to increase the stability in the long run. And we also have to consider that most of the patients that we treat today are treated by means of adhesive materials and polymeric materials. So the optimization of the photopolymerization of this light curing process is something we have to prioritize. And when it comes to investment in our clinics, we have to invest in very specific things that will increase the quality of our practice and what we deliver. And you in Europe have a great history of that, and in Latin American countries and developing countries, it's a little bit different than what we have. And perhaps in Turkey, you may see that the link between these two different ways of seeing the dentistry, more traditional, more conservative, goes like this. If you magnify what you're seeing, you prepare less. If you see better the difference between the materials you are preserving and the materials you're trying to improve, you will be able to have a better stability when it comes to biocompatibility with the tooth structure. So it is not only a matter of optical characteristics and characteristics of aesthetics. It is basically something that we have to see in the capacity of the tolerance of the tissue that are surrounding restoration and the capacity that the restoration has to work as one with the tooth structure. So for me, it's a very great topic to talk about. And I see that one of the most common errors and one of the most common failures when it comes to restorative dentistry, and specifically when it comes to this type of approach, we see that we don't consider sometimes the biology of the patients from the very beginning. And we place restorations that sometimes are facing this peri-restorative restoration failure because of the capacity of the microbiome to adapt around the restoration is so aggressive. And we can see all the colonies of different bacteria and complex microbiome that we can have around a restoration. And if the restoration has a mode of failure that goes into more hydrolytical failure rather than an enzymatic failure that we can see in different studies, the failure scenario will reduce the capacity that we have to preserve. So the concepts of invasiveness has evolved. All these concepts have evolved for many years, and we have been reaching this possibility to keep as much tissue as possible. And perhaps you all know this magnificent work of Professor Daniel Edelhoff that changed the consciousness of all of us when he was able to prove that when we prepare full crown shoulder, we lose the 70% of the mineralized strength of the tooth structure. And then we started to work with enough space to restore, to change what the patient needs, but not to compromise the stability in the long term. And it's very interesting to see that since 1982, Professor Urs Belzer gave us this perspective, and until 2013, we can see in many publications this trend to minimize the preparation, and we all work today with this scope of minimal invasive dentistry by means of making a mock-up, for example, in patients that are demanding an aesthetic modification or improvement by means of indirect restoration. That I'm going to move a little bit towards that because I'm running out of time, but I would like to share with you a couple of I don't know if I can see the cases, but I would like to share with you a couple of concepts. Most important thing is that when we are going to prepare a tooth, we have to be aware of what is going to be the last part of the treatment. If we're going to bond, we need to polish as well as possible. We need to polish in the best way we have a chance to do, so we can increase the capacity of the tooth to magnify the restorative tooth structure interface bonding, and we can create the better conditions for these restorations that are are thought in the minimum invasive way. As you can see here, for example, this is a very conservative preparation, the so-called contact lens, and sometimes I don't want to tell you that I'm in favor of contact lens preparations, but I can tell you that I'm really prone to go to minimum invasive restoration because sometimes the regular protocol doesn't give us the chance to preserve as much as possible. Sometimes patients are coming with affections that are more profound, and they have experience before restorative work, and we have to make a flow of restorative treatment that comes from the prevention optics to the treatment planning by means of analogical possibility to recreate the form and function, and then go into the deeper needs of the patients. And for example, in cases like this, where we normally tend to use preparations with depth of more than 1.5 or 1.6 millimeters, we have this possibility to go into a more conservative approaches by means of the new optical properties of the materials that we have in hand. And in this particular case, I just want to share with you this experience because we try to reduce the damage that we were going to create by preparing the tooth structure of this patient of 52 years old when he came to the clinic. And my periodontist and my ceramist specialist were more or less on the same idea of trying to preserve as much as possible. And we tried to keep the preservation parameter in a preparation maximum depth of 1.2 millimeters or 1.4 millimeters when it comes to facial aspect, but over the mock-up. So when we see the models afterwards and the preparation was delivered to us with this restoration, were delivered to us, we can see that we were able to change the color and we were able to change the overall aesthetics of the patient with a 1.4 millimeter restoration that was very conservative. And we really like to have the chance to preserve as much as possible of the remaining enamel, because you could saw in the previous pictures that there were cracks and there were restorations and there were very damaged structure, and there was also a periodontal compromise that we wanted to address by a conservative way. So the patient ended up with a restoration that changed his self-perception and this 52 years of discomfort and happiness with his smile changed afterwards. So we tried to go, we tried to move into this minimal invasive treatments, and we tried to preserve as much as possible, but rationally, and we try to go in a way that improves the quality of life of the patient, the biology, the biomimetics of the restoration, and in the long run, we want to change, for example, with this type of restorations, when we are changing failed restoration that have problems of leaking and planning of length of, for example, this Boston core with metal restoration that was actually a failure, and the patient came 2 days later once we started with a diagnostic imaging and model taking. The patient came with a crown that fell off eating something soft, and we decided to go to a minimally invasive protocol by making an intracircular incision to allow me to go deeper to the tooth to place a post, because we were really lacking of full effect. And then we went to reconstruction of the stump by using a restorative approach, increasing the thickness and the length of the abutment, and then we can see that we can improve basically immediately the biologically driven aspect of this restoration by creating a space that was not there before, and stabilizing the tissue around by placing just a couple of stitches, and then we wait until we have the chance to place the final restoration and to give to the patient a stability and the capacity of having a nicely adapted to the biology and to the aesthetics restoration. And the last case I would like to share, if the time is in possibility, if Dr. Ezra allows me to, just 3 more minutes, to show you that from the reality of the digital smile design, change the way to see this type of treatment, because we can plan, we can make an essay, we can make a test drive of the patient, and not only by means of this emotional aspect of the treatment, but also the functional aspect of the treatment. We can go to the planning, and we can go to the improvement of these aspects, and go to this biologically oriented type of treatment by creating individualized wax-up. In this case, in particular, for myself, was a very nice challenge of additive wax-up. And we try to do the best possible treatment in a conservative way by only adding materials without taking too much tooth structure from the patient. And the patient has nice biology and very pleasing thickness of the gum that allows me to deliver not too invasive, but not too perfect treatment, but was natural in the end. So when the patient went back at home and showed his father the treatment that we tried to make in Mexico, and we tried to develop the best minimally invasive and high aesthetics and high performance bonding for the patient in the mouth, this is what he got. And these ceramics were made by my friend, Dr. Juan Delgado from Guadalajara, who's a skilled dental technician, but is a great clinician as well in implant and restorative dentistry, and is one of the greatest teachers in Mexico. And all the cases that we face have a unique touch of a specific needs to create the best challenge and most individualized treatment planning that we can develop. And in this case, you can see we try to go into the minimum invasive aspect that we can provide to the patient to preserve the maximum the tooth structures. We use the technology that was linked to dentistry in 1990s, cross-polarization, that I know you use very common, because there are very skilled dentists and technicians in Turkey, and many cases that have been shown to the world in the publications worldwide, and we can see that you do this type of approach to by means of this biological, aesthetic, and functional provisional to create the shapes and the textures that we are willing to deliver to the patient in the final restoration. So individualization of the treatments is also a need that we have to create, and sometimes it's a very challenging need for the dental technician, and the CERMers are our best friends on that, because they try to do their best with the minimum preparation we provide them. So we try to reduce the degradation of the tooth structure by means of a protocol of minimal invasive approach that allows the patient to have more teeth to be restored in the future. So to end up with this participation, I can only state that this type of work worth nothing if we don't prioritize the prevention component, because once the patient is restored, the patient needs to preserve. So they need to be aware, they need to be educated, they need to be trained to increase their capacity to maintain not only the restoration, but the most important thing, the biology. And without a good biology, there's no restoration that will be useful anymore in the future. And I repeat, the name of the game of this approach is the prevention. And the patient is the responsible for this part. And if they are aware and they are bonded to their treatment plan, they have a better possibility to go into older ages with their natural dentitions. And that's what we are willing to. And this image is a courtesy of my friend Victor Guerrero from Peru. And they created these magnificent structures that lasted for over 2,000 years. And you know that the most durable restorations in dentistry are gold casts and gold foil restorations. And unfortunately, the patients are not looking for this anymore. In the anterior dentition, it's very difficult to have this. But now we are in this race of the companies and the dentists and the dental faculties all over the world to bring education that allows us to maintain the capacity of improving the lifespan of the restoration and the success of the restorations by means of these biomimetic approaches. So I really thank you for this time, and I would love to share with you this reflection by Dr. Richard Tucker, that is to preserve the dentistry as simple as possible, but without sacrificing the excellence. So it is in our hands to have the chance to develop this consciousness and to deliver to our patients more biomedically driven approach treatment plannings, and obviously try to preserve the more we can the stability of the patient in the long term when it comes to start a restorative cycle. Let's try to avoid it. It's not late, and it was very interesting for me to see that Professor Greenbardigan Black once stated that there will come a day that you young men in front of me are going to be immersed into more preventive practice than into a restorative practice. And that was stated in the end of 19th century. So for us, that's the message to take home. And I hope I have created some things to thought for the rest of the week. And Professor Ezra, I would like to thank you for this invitation, and just leaving you with this final this final thought. Okay, do we really need better biological material than the one we have already? Do we really understand the complex scenario of this biosis in the mouth of our patients that are challenging every restoration we're placing now? And now in this time of pandemic, we have seen an improve of the consciousness of some patients, but we have seen also the complication of patients that were healthy in the past. Do we really need faster biomaterial, and or do we need a better, clearer understanding of the stability of the long term of the restoration in the oral environment and its interactions? And actually, do our patients really understand our job and the commitment in the long term that we have established with them and with their health? And last but not least, in this reality now pushed and marketing driven, the dental practice has been pushed to a limit of social media, but social media are not necessarily bad in this case, are magnificent tools to share, to increase the awareness worldwide, and to share experiences. And today is what brought me to be able to talk with you. So I really thank you for your time, for your attention, and Professor Ezra, it's been a total honor to be able to share this time with you, and hope I brought some interesting ideas to your agenda. And if not, I'm really sorry, but I'm trying to do my best and trying to do the best in the clinic for our patients, and looking forward to improve our knowledge, our skills, and try to develop the best treatment possible that we have. We're not perfect, but we're perfectible. Thank you very much.
Okay, Professor Sergio, thank you very much for this very nice, informative, and well-designed presentation. Yes, it's very, very good topic, because nowadays, generally, the operators focus on aesthetic features of the restorative materials and also techniques. But yes, we have to follow biomimetic and also minimally invasive approach during making a restoration. But nowadays, as you said, yeah, social media, because of social media, generally our patients have very high aesthetic expectations, and sometimes to balance it is really very, very difficult for us. In the past, yes, they generally prefer not to make any invasive restorations. But nowadays, aesthetic dentistry is really, really very, very important for both patients and also the operators. And also, yes, you're right. Yes, with the adhesive dentistry, we can really prepare very non-invasive preparations for veneers, or for all restorations. We can get non-retentive preparations. And yes, we have really good materials for restorations, as a luting cement also. But yes, the problem is, I think, our patients' expectations.
Absolutely.
Okay. Yes, because I'm sure all of our colleagues generally recommend to their patients first the most minimal invasive method for a restoration. But sometimes, unfortunately, our patients' desire is different.
Yeah, and they are willing sometimes to make a fast, immediate change and wow effect, and they are willing to pay not the economical part. They are willing to pay the biological costs of it, and trust me, that I am really concerned, because I see now younger patients going to more invasive treatments that maybe many of us can consider over treatment, because they are willing to have the fast track treatment instead of going to the most preservation wise oriented treatment, like for example orthodontic treatment, periodontal treatment, and perhaps make the minimum adjustments by means of prosthetic work. So it's complicated to see that now you see patients 16, 17, 18 years old patients asking for veneers, and it's not the same to place a contact lens or prepless veneer in space that you have to close by adding material, then have to open material that's destroying tooth structure to change the axis position and to improve the aesthetics by means of destruction of dentin and by means of destruction of enamel that are biologically the worst investment you can make in the long run. So yes. I don't know. It's good to see that worldwide this consciousness of biomimetic approach or minimal invasive dentistry is going to a more popular presence in social media, congresses, and so on. It has been increasing because in the past, in the 2000 year, the decade of the 2000s, minimal invasive dentistry was only for pediatric dentistry. And then that became a game changer in prosthodontics and restorative dentistry. So I'm really glad to have this possibility to apply these concepts that I was able to learn in Europe and bring them back to my country, and then have the chance to change patients' life, because I was able to have the access to teachers that changed my consciousness. So that's something I cannot thank enough in my life.
In also restorative dentistry, we give very importance to minimally invasive methods, but sometimes we have to do more invasive restorations.
Absolutely.
And also, your cases are wonderful, and you show the dental fluorosis case. Yes, also I studied in a endemic fluorosis place in Turkey, and yes, nearly 10 years ago. At that time, I had a chance to aesthetically restore aesthetic management of very much dental fluorosis cases. Yes, resin infiltration method is a good method. It's a new method, relatively new method. But sometimes, in especially moderate or in severe cases, we couldn't get good results. And also, I prefer to use this method with dental bleaching. What do you think about this? To use resin infiltration with dental bleaching to increase the aesthetic appearance of the technique, maybe.
Yeah, that's absolutely that is very useful, and it's very desirable. And sometimes the only objection from patients that I face, I don't know if this happened to you in your experience, but the time frame that you have to wait in between. So you have to wait after dental bleaching, and then you go to infiltration technique. And some patients are not willing to wait 2 to 3 weeks to do one before the other. And sometimes in cases that are not so severe, you know that sometimes we can do only this abrasion.
Microabrasion.
Yeah, exactly. Microabrasion works perfectly. And also bleaching improves the overall aesthetics of the patient with a very minimum of invasive treatment. So yeah, I'm really prone to see all the scopes of these possibilities of treatment whenever the patient allows me to. And I don't know if in your experience it happens often, but in Mexico, sometimes many of these patients having fluorosis present vertical cracks or horizontal cracks in the enamel. And that sometimes restricts a little bit the capacity of having nice bleaching without these hypersensitivity issues that you addressed magnificently in your presentation when you were able to share with my students in few weeks ago. And but these techniques are sometimes also sensitive or limited to the materials. And unfortunately for us in Mexico, we don't have the whole scope of materials that you were able to show. And that's a pity, because restricts a little bit our capacity to make these more conservative approaches and improve the quality of aesthetics and self-perception in an easier way.
Okay, thank you. Also, we have some questions. We can take questions. Professor Funda Yanıkoğlu, also she is the organizer of this organization. Yes,
Okay.
she congratulates you for this very nice presentation on minimal invasiveness, and she asked a question: is there any complications of using resin infiltration technique in long-term clinical period?
Yeah,
for example, coloration maybe.
Yeah, there are two major concerns in that type of treatment. First of all, the amount of material we use, because it's a material that has no the best physical and mechanical properties, but most important thing I think is the physical properties. So if we use an excessive amount of this resin, or the layer is too thick, we can face in a short time a change of the color of the restorative material. And yeah, discoloration is an issue that you can see in this type of cases, depending on the habits of the patients. For example, patients that are more prone to smoke and to drink red wine and stuff like that, or drink too much tea or coffee, like in natural dentition, they also get stained. And you can see this type of pigmentations, or micro pigmentations, within the first year or the first 3 years. Is my most complicated experience. But therefore, we have to go very thoroughly to the process of polymerization and the process of polishing, because the polishing retention is what allows us to keep the stains away. And you cannot polish properly if you don't light cure properly. So it's very interesting to see how the dental material basic sciences come to a very practical approach when it comes to one of the most popular minimum invasive treatments nowadays. And we see that these concepts are very important to the progress of the technique, and actually to the good stability in the long term for the patient, because we don't want to have to be able to make infiltration again and again every 3 years. That actually, I can tell you, that was my major concern when I started to apply this technique, because the development of 1998 of this technique didn't offer evidence. So was not evidence-based, was more experimental. So we went to get the material and to apply it into many cases. And what made me think many of the factors that I spoke earlier was the work of a colleague in France. I missed her name at this moment, sorry. But this prosthodontist is very talented. Marie.
Maya Luque?
Yeah, exactly. Absolutely. So she's inspiring. And her work allows me to see many of the complexities of this process. So therefore, I said in the end, I really thank the social media to give us the scope of share these ideas and put people in contact that we never imagined.
Yes. This resin infiltration technique was first developed for initial caries.
Yeah.
For initial caries.
D1 and D2 maximum.
Yeah. But the hypomineralization lesion and initial caries lesion are a little bit different. The demineralization area is deeper in hypomineralization lesions. It can affect all enamel in some cases. And so maybe the success of this method is lower in hypomineralization lesions compared to initial lesions. Maybe, especially aesthetic result may be different. Also, there's one more question about contact lens like laminates. Is it different from prepless laminates?
Yes. I don't know if you're familiar, perhaps you're all familiar with the concept of Dr. Osvaldo Escopin de Andrade from Brazil. And he said, okay, the contact lens technique is normally a prepless technique, but I followed one of his concepts. We were able to talk in a lecture meeting, and he said, okay, the best way to stabilize a ceramic on top of a tooth, if you don't want to have a long space of resin that can change color and migrate and biologically affect the patient, is to create a micro stabilization preparation. And I see, for example, that in Western Europe, there's a lot of education on that and a lot of training by using a microscope dentistry, and magnification is very common there. And try to create this 100 micron preparation with naked eye is barely impossible. I can say it's impossible because you're not making a finishing line, but an imaginary line of preparation. And it's very difficult to get something that is stable in the long term. And in my particular opinion, I can tell you that I go to a micro preparation approach rather than a prepless approach. Yeah, because it's quite difficult to achieve, especially when you are close to the gum.
For retention or for
retention is not a problem. Biologically speaking, the problem close to the gingiva is the difficult part to manage sometimes. If you are not skilled enough, you can harm or you can modify the environment. And you know that when you place something that is not welcome there, the cytokine reaction that we can create will eventually cause irritation, and inflammation process can go in the long term to create modification of the gum and the bone position. And that was sometimes linked to a restoration placed close to the sulcus. So yeah, I'm not so prone to the prepless preparations because of that. And I did a lot. And I have a couple of articles that were published with that technique. And I cannot tell I regret, but I can tell I'm not using that anymore as my first option.
Okay, now our time is over. Just one more question. Any micro leakage research done with resin infiltration technique? There's a question about it.
I've seen some in the International Association of Dental Research, not much published in journals. And I could share, if you want to contact me via a direct message on Instagram or Facebook, I can share you the link so you can take a look at this content. But there are some issues with micro leakage, but it's after 3 years or 5 years, as far as I remember, because as all dental materials that are based in carbon reaction monomers, they can become later on, as Professor Franklin Tai proved in 2007, as far as I remember, they become membranes that are permeable from in and out and in. So all these materials are exposed to this hydrolytic phenomenon. So
yes,
it's part of our reality.
Yes, I think penetration ability of the material is very important, and also the depth of the these gaps, subsurface gaps, is very important. There can be micro leakage within time if it's not filled all these gaps very well. But if the operator apply the technique properly, yes, it's gonna be successful in also a long-term clinical period. Yes.
Absolutely. So therefore, the operator may make the difference.
Yes. Okay, now our time is over. Really, very, very good, I think, presentation. Thank you for participating in this organization also. Okay, then we can close this session. See you later. Okay, bye.
See you. Thank you very much. Bye.